fantastic presentation from our community palliative team, sharing with us a couple of patient stories, which I think made us both extremely humbled, but also immensely proud of the work that our community palliative team do. So thanks in particular to Joe and Marion, who were presenting this morning. We then had a discussion on mental health issues and service needs and the development of mental health illness in Coventry and Warwickshire. So a busy morning. So moving on, as well as having a substantive discussion led by Helen on how we become an exemplar on cancer performance, which is our objective. So any new declarations of interest? Please raise a digital hand if you have any new declarations of interest. The last set of minutes, was everyone happy with the last set of minutes? If you want to make an amend, could you please raise a digital hand? Yasmin?
Thank you, Chair. I'd like to bring to your attention that your statement regarding our zero tolerance approach to racism at the start of the last board meeting doesn't seem to be recorded in the minutes. Okay, thank you, Yasmin. Can we make sure we change them accordingly, please, Sarah? Just to reiterate, and I know Glenn comes back to it in his Chief Executive's report, we have a zero tolerance of racism at the Trust. Patients who act in a racist manner need to be aware that that is wholly unacceptable. And in terms of colleagues who suffer racist abuse, they need to know they have the full support of the board and the expectation of colleagues to step in and support them if a racist incident occurs. We are proud of the diversity of our workforce and our colleagues. We are a strong promoter of inclusion and equality as a board, and we need to ensure that that's what I said last time, as you said, Yasmin, that is properly recorded this time. Any other amends? Okie dokie, thank you. So in terms of action points arising, we go to page 16 of the pack. And the first was to Fiona to ensure an update on the recommendations regarding the Ocondom review. That is complete and is on the agenda. Thank you, Fiona. Then Kim to bring the second half of the plan once those details have been confirmed. That's on the agenda as well, but I think it's still fair to say, Kim, that we are driving through fog when it comes to understanding what the regime will be in the second half. Then Fiona to ensure that a covering letter be sent to CNST explaining why there were limited safety concerns in order to maximise any financial contribution to the organisation. Fiona, thank you for doing that. And Fiona and Kim to provide me with the outcome of the percentage of Tier 1 nursing agencies. Thank you for doing that, Kim. The way we were able to present that data was more comprehensive than other parts of the foundation group, so well done on that. Then Glenn to keep the board appraised on progress with the CWPS network. Glenn?
Yeah, we actually do have the promise of a meeting in September of the network. Hopefully, maybe not by the time we next meet, but by the meeting after that, we'll be able to give an update on the position. Super, thank you, Glenn. And then Helen to come back on the point prevalence survey outcomes in September. Just to remind members of the public who may not be aware of the phraseology point prevalence, point prevalence means we do a snapshot at a point in time as to where patients are in the system and where they should be. And we compare the costs of where they are to where they should be. And every time we've done it in the past, there is a very substantial saving. So that will be presented in September. And thank you, Kim, for clarifying discrimination of any kind in the chat box. Then the executive team to ensure that non-clinical staff be reviewed on a quarterly basis to see where staffing challenges were prevalent. That's ongoing, so please do that. And then for the future, Charles to bring back the medical revalidation report in November.
including separate trend data, so we look forward to that. Gertie to invite 2 members of the BAME network who'd been allocated places on the National Res Expert Programme to attend a future workshop. That's scheduled for October, November. Thank you, Gertie. Then trust-wide oversight of work streams as part of the board assurance framework and mitigation be held every 6 months in a board workshop. That's planned for next month. Thank you, Anne. And a Black Swan event training is also planned for next March and next September. And then Sue Pike to ensure that registered nurses and midwives data be broken down into 2 separate groups within the Who Was Speaking Up by Profession graph, and we will see that in September. Are there any matters arising that colleagues think I've missed? Now, some of us will have the experience and occasion of pulling teeth, or the phrase pulling teeth. The first thing on our agenda is something which feels a bit like pulling teeth, which is a business case for the Community Diagnostics Hub. So, Sophie, over to you.
Thank you. So this is good news at the board today, really, because the board will be aware that for a number of years now, we have looked to develop a community diagnostic hub over at Stratford. It's been part of our strategy for at least 5 years, and the board approved last year for us to start to spend some of our capital to realise that ambition by moving our diagnostics department out of the old hospital into the new hospital. What this national funding has enabled us to do is to continue on that journey around developing that service further. And in the workshop today, Helen talked about the work that her and her team are doing with the GPs around straight to test. So the benefits for our community around us starting to work differently with our partners and bringing some of that diagnostics close to their home is absolutely, again, aligned to our strategy. So across the system, Coventry and Warwickshire have been working together. It's a new way to work. It's been an adventure. And we've agreed a strategy around 3 diagnostic hubs across Coventry and Warwickshire. So that's 1 in Coventry City, 1 at the George Eliot Hospital and 1 at Stratford. And this is also in line with the national strategy about 3 diagnostic hubs per million population. And we're just under for Coventry and Warwickshire. So in the confidential board today is the system bid. But what I'm here today in the public board to talk about is that what does that mean for SWFT and the population we serve in South Warwickshire. So key things around this paper and what we want to do in the first year is around our MRI capacity. So we're looking to put a fully staffed MRI onto that Stratford site. Because nationally all systems are putting in those bids, there's high demand for staffed MRI or staffed CT scanners. And our procurement team have worked really hard to manage to secure us one. So you'll see today I'm asking the board for approval to proceed with that at risk. It is one of our highest priorities in terms of diagnostic capacity. And if we aren't able to place an order soon, we would not be able to spend the money this year. Similar to when we had the conversation at board around the national funding for the PAU and the pre-op assessment. But also there are other trusts that are looking to purchase that MRI. And so we know that that's the only way we can get some extra capacity into our system. The other elements I'm looking for today is around some of the staffing. Again, this is a hard to recruit area, so we need long lead-in times. I'm seeing nods from Sarah, long lead-in times to get staff because often it's from abroad. So the ability to go out now for some of those posts. If the funding wasn't received for any reason, we've got gaps within our diagnostics department, so we would be able to manage those. So the risk is relatively low. So the paper today talks through exactly the services that we want to put into Stratford, into our community diagnostic hub to start answering the national strategy and starting to look differently about how we use diagnostics closer to home. There's been lots of discussion in our system around health inequalities, and often you can go to the obvious place, but actually we've been really fortunate that Duncan's helped us. Duncan Vernon, our public health consultant, has really helped us think differently about that access to diagnostics from our older population and also from a rural community. So the bid that we put in as a system got recognition from NHSIE has been a very good bid. It's been through Community Diagnostics Hub meetings that Catherine Free, the medical director at George Eliot, chairs. It's been through the finance group for the system. And so that system governance has signed that off. And that was what was submitted for our year 1 bid. It's fair to say now we've got quite a lot of work in the system to do on our years 2 to 5 strategy to understand the affordability of it and to really get into the detail on the demand and capacity for diagnostics over the next 5 years, and understanding where, if possible, we could share some of those resources as a system and where we actually need them in our own diagnostic hub. So the paper also sets out a really high level view of that 2 to 5 year strategy. Hopefully that's not a surprise to anyone, because we have talked about it here on a number of occasions as one of our ambitions. So the paper today and the recommendations is asking boards for to move forward at risk with those key things that we are unable to wait any longer. We will not be able to get that capacity in. So I'll pause there for questions.
Thank you, Sophie. And I think I'm correct in saying this came out of the Richards review, which looked at diagnostic capacity across the UK and concluded that there wasn't enough diagnostics capacity, and that the diagnostics capacity should be built at a local level rather than a centralised level. Just before I come to Glenn, Charles, I assume this has your full support?
Absolutely. And as you say, you know, if you look at the UK relative to other Western countries, we are very, very low on diagnostic capacity, and all the work we're thinking about in terms of cancer early diagnosis, you know, this is really important thing to go ahead with. So I absolutely support it. Thank you very much.
Questions and perspectives, Glenn?
Yeah, thank you to Sophie for her work on this, and for Catherine Free, the medical director from George Eliot, who's put a lot of work across the system into this. I mean, one of the problems at the moment with the way the NHS is working is the bidding processes that we're having to enter into in order to get access for things that we need. So despite this being, the funding being announced a number of months ago for this, we, as Sophie said, are still waiting for confirmation of the funding. That said, it was a really strong case that was very well received by the regional team. And in fact, they gave us slightly more than we were initially expecting, and we've therefore been able to expand the bid a little bit to accommodate that. But in order to make sure that we utilise that funding for the system, we needed to move forward at risk. But it's, and I think last month actually in my chief exec's report, I talked about some of those inequalities, and I think that kind of reinforcing the number of people in old age living in poverty in Warwickshire is higher than in Coventry. The distance to travel to services is a significant issue of inequality, and that we do need to ensure that we tackle. And that's why using our Stratford site, which is already developed, a diagnostic hub is a great solution to that. So I'm very, very supportive of this. It was also it's been signed off by a lot of groups across the system. So it went to the provider collaborative meeting, which I chair, and then to the partnership executive group. So it's had sign off in all of those places. So hopefully if National confirm the funding, we'll be able to crack on with it very quickly.
Thank you, Glenn. Rosemary?
Thanks, Sophie. Can I just have clarification on 2 points? The first, unless my thinking's wrong, I thought we've already do have an MRI scan at Stratford, which was a business case about 4 or 5 years ago, and there was concern at that time whether we'd actually reach its capacity. So are you telling us that is actually now working at full capacity and we need a second MRI scanner for diagnostics?
Yes, however, the problem we've got at the moment is staffing to be able to get it up to 7 days a week, 12 hours a day, etc. So because this unit comes fully staffed, it allows us that transition then to build up our workforce as well. However, I have got Jit with us at the board who's done the modelling around the MRI capacity, which does show that we will need 2 MRIs in the future.
Right.
And so just for members of the public, this morning on our presentation on cancer, we talked about a 30% increase over the last 2 years on cancer referrals, which sort of shows how demand is growing. And did you have a second question?
I did, yes. And I know the figures at the moment are only focusing on year 1, but it did strike me that in year 2, the figures that you've got on page 4 of the report, you're showing like a full year's cost for NHS staff, whilst you've still got the independent scanner for half of the year. So it would seem as if there would be some potential for cost savings there, because you could continue to use the translocase scanner for the full year, whilst obviously recognising there will be some need to bring staff in to train over, but I'm sure there's a bit of savings we can make.
Yeah, so if I could just, I should have added that. So we're unable to just have the scanner for 6 months because it's in such high demand. So we're only able to get it for 12 months, which is why we have to keep, which is why it's become our only option. And we discussed that quite a bit in execs and management board, because if we could get it for 6 months, it's completely funded by this national funding of year one. But procurement have looked into it, and we can't just have it for 6 months because so many people are after it and they're asking it for a longer period. So the independent sector funding is due to stop in year two. That being said, as a system, we're still saying that we would like some support from NHSIE funding for year two. Does that make sense?
Well, all I'm thinking is that we can delay getting the permanent solution,
Okay.
Staffing thereof, until we've used
Yeah.
Yeah.
Well, I've got lots of hands up, so just keeping things moving. Can I go to Jeff first, please? Jeff?
Yeah, just for clarification, what size magnet is this, please, going in?
I'll have to find out for you.
Okay,
Jeff.
thanks.
Okay.
I just want to make sure that it's actually the right magnet for the diagnostic testing we're going to be using for cancer and so on.
Yeah, sorry. Procurement and the diagnostics team have signed it off, and it is a good standard unit that our radiologists have confirmed they're really happy with the unit that we've managed to secure, because that was one of our risks, that we wouldn't be able to get a unit with high enough quality images, but that has been done through procurement and the diagnostic team.
Okay, thank you.
Thank you, Sophie. And Helen?
Thank you, Chair. I just wanted to add my support to this and just reiterate that actually the community diagnostic hub is really one of those very first elements around us changing our pathways significantly, but also future-proofing the organisation. And as we talked earlier on this morning, Russell, around us starting to scope out what our demand's going to look like over the 5 years. And within the paper, you can see the projected MRI demand for the next 4 to 5 years. And so we are future-proofing the organisation, I think, for those significant increases in demand that we are seeing, but also about this collaborative approach that we have with working with our partners, about changing the pathways, working in new ways. But in the interim, this will allow us to also potentially provide mutual aid to the system while we are going through that process and while we're waiting for that demand to catch up. And I think a mutual aid across the system is really, really important, so that we are addressing those health inequalities and those patients that are waiting longest across the system. And so there won't be any spare capacity. If anybody worries about that, we might just then start to step back on the mutual aid as the other schemes across the system come into play.
Thank you, Helen. And finally, Charles.
Yeah, I was going to say something similar to Helen. One, MRI is really growing. There's no radiation. The technology is getting better. It's definitely a growth area. And two, I just can't envisage a position where we've over-recruited radiographers in terms of capacity.
You never know. We live in hope. And Kim is saying she's supportive of the case to proceed at risk. Thank you, Kim. So if you're not happy, sorry, do I have one more? No, that's Charles. So if you're not happy to approve this business case, could you please raise a digital hand? Duly approved and recognition at risk. Sophie, go make it happen, please. So we'll move on then to the Chief Executive's report, and if we can keep the pace moving because we've got a lot of reports to cover, please.
Noted, Chairman. So I'll focus on the most important item, which is the first one. And we've already talked about this at the start of the board meeting. So a really powerful development programme that the board have been undertaking with the NHS Leadership Academy, which led me to take the opportunity a couple of weeks ago when the issue around the footballers was in the media to talk about this from an NHS perspective, because what the footballers faced is something that a lot of our staff face on a daily basis. And so I've included the tweet that we put out, and it was really good to see the level of support that had, and the attention it attracted. In fact, elsewhere, we ran it in the other parts of the group as well, and the local media in those parts picked it up also. I mean, what we're saying here is that we absolutely recognise the professionalism and the professional responsibilities of our staff to look after people in an emergency, and to understand if there's confusion involved in any kind of act of aggression towards our staff. But what we're talking about here is calling out the overt racism towards our staff, but also other discriminatory behaviour, and it's also important that we call that out also. So we've started a campaign. There'll be more posters around the organisation that will support our staff, give clear messages to our patients, and I think the most powerful thing that I would like to see is some of our non black and minority ethnic staff actually standing out and calling this out, and being the ones, rather than the victims, being the ones that actually say that's inappropriate, we don't accept it here. And if there's if we're talking about planned care, if an individual refuses to be treated by one of our BAME staff or staff with other characteristics, then they're refusing to be treated by us. And I think that's a really important stance for us to make, not to pander to it, as I say in the tweet, but actually to say that that's unacceptable. So we'll be doing some more work on that. I will just draw a couple of other things out of the report quickly, Chairman, because you gave me that time warning at the start. Revised isolation rules are there. These are helping a little bit, but we are still, it still excludes household contact. So those staff are still isolating, and that is having an impact on the service at a time when urgent care demand is extremely high, as well as recovery of elective and cancer activity. And that's something I'm sure Helen will talk about a little bit more later on when we do the performance report. And as a consequence of that, we are still absolutely keeping restrictions within NHS practice, infection prevention and control, wearing of masks, and again, calling to members of the public not to be aggressive towards our staff if they're asking for masks to be worn. We're protecting them, our staff, and obviously some incredibly vulnerable patients from time to time. Talk about review of information services, which will move to a more standardised reporting pack for all of the 3 boards in the group. And then a feature on the special care baby unit and some of the activity that they've undertaken throughout COVID, with some very high numbers of 338 admitted to SCBU over that July 20, July 21 period, and the way that they've had to deal with some of the restrictions around relatives visiting and around mothers visiting, and have managed that incredibly well. And then it also goes on to talk about neonatal outreach service, which is being developed across the system, which will help us to reduce the hospital occupancy of our neonatal units and give us more capacity. That's all I wanted to go through. Happy to take any questions.
That's great. Thank you, Glenn. Any questions or perspectives to Glenn? Stunned everyone into silence, Glenn.
All in agreement, Chairman.
Yeah, no, that's good. That's good. Okie dokie. So we'll move on then. And Helen, you're kindly stepping in for Anne to give us an overview of the Integrated Performance Dashboard, please.
Thank you, Russell. It's clear from the report that the Integrated Performance Dashboard reflects the ongoing impact of COVID-19 recovery, but also there is an improvement use of data and recovery of the services, so that's really positive to see. The Director of Nurses commentary this month documented the exception report and highlighted that the majority of quality and safety KPIs are in a strong performance position. That there are 2 that have been affected by the COVID-19 pandemic which have not yet recovered, and that's primary PCIs and venous thromboembolism, but assurance has been provided on the actions being taken. The increase in the children in crisis being admitted to hospital remains a problem, and it's noted that the Director of Nursing has concerns regarding the lack of system progress. The Director of Ops commentary documents ongoing increases in A&E activity during June, and with corresponding increases in admissions. There is a positive evidence of impact of same-day emergency care, and that impact is having on a reduction in the length of stay. Delivery of the elective recovery fund at 75% and 80% value have been met through May and June, and the collective system focused on delivery, sharing good practice at system, productivity and embedding use of the improvement trajectories. And there continues to be significant reductions in the numbers of patients waiting a year for treatment. Cancer performance, as we discussed this morning, remains challenged. However, we're starting to see signs of stabilisation and steady improvement in the performance and quality of the service. Out of hospital teams' performance against the 2-hour urgent response standards remains consistent, and it's positive to note the development work underway with West Midlands Ambulance Service in supporting improvements in this evolving pathway. The Director of People and Organisational Development commentary notes that despite recruitment to the Trust remaining encouraging, a slight increase in sickness absence combined with a significant rise in self-isolation, as mentioned, has impacted heavily on overall staffing availability and levels during June and July. At month 3, the Director of Finance notes the Trust has delivered a 53k surplus compared to a break-even plan. Just move on then, Russell, to any of the overarching reports.
That's great. Thank you, Helen. Don't think we need to. You've covered everything. Very comprehensive. Thank you very much. So questions or perspectives to Helen before we move on to detail, Bruce?
Thank you, Russell. It was just a matter of saying I'm not quite sure who would want to answer this one. What's happening in the system progress coordination around the mental health children in crisis area? Who's asking which question where and where are we? This was a subject from, I think, 2 months ago's clinical governance. Yeah, no, great. Thank you. Glenn?
I saw Fiona's hand up went up after mine, but I mean, we talked about this at the board meeting, I think for the last couple of meetings. I'm sure Fiona will touch on it later. But we've got an improved position, but we shouldn't be lulled into a false sense of security on this, because the improved position in terms of the amount of mental health activity on our general paediatric ward is because there's been a lot of focus on this, and a lot of senior focus and people making sure things happen. I think we need assurance that we've got a sustainable solution in place, and we need to work really closely with Coventry and Warwickshire Partnership Trust, who are obviously the main service provider, to ensure that is there. But I'm sure Fiona would want to comment on that also. But it's better, but let's wait till we've seen the sustainability solution.
Okay, maybe come back to it, Fiona, in your report, if you would. Helen, anything you want to add?
Yes, thank you. We did talk about this at the Chief Operating Officers meeting at lunchtime, and I think what we have noted, and I know Fiona leads on that for us, is that we haven't yet seen a business continuity plan or a surge plan from the Partnership Trust. And so that is the next push that we are asking for. We've all brought together our winter surge plans for paediatrics, and we know that we can manage those surge plans for children that are physically unwell. So we need to have the surge plans and the business continuity plans for those children that have mental health difficulties, because we can't manage both as a system.
No, point and risk understood. Thank you, Helen. Colleagues, happy then to move on to Fiona's report? Fiona?
Yeah, thank you. As Helen's kind of covered, my summary was most things are in a good position or improving position. I just want to correct that there was an acronym that was incorrectly explained, and it should say patient care indicators rather than percutaneous coronary interventions. The issue I wanted to put out was the children in crisis. So as Helen and Glenn have said, there is some improvement in the short-term position that and impact into our services of the increase in children in crisis. But I have stated this quite bluntly, I'm not assured about the long-term trajectory on that. So it's hand-to-mouth management of these children, and we are working well with partners in that hand-to-mouth way. But when we are asking as a board and as individual executives for their planning assumptions, their capacity and demand modelling, their business continuity plans, we're not getting them, and that is being escalated via Glenn to Gold and via the chief execs through Helen. So there is a task and finish group being pulled together, and Glenn has released some resource from George Eliot to help with that. But at the moment, I'm not assured that there's any traction in that.
Well, please keep us briefed on that, because that's clearly important. Questions and perspectives to Fiona? Chris? Chris, you're on mute.
What's the CCG's response to this, Fiona?
Well, they are currently chairing the Silver Command and escalating themselves to Gold. Glenn may have a better view in terms of Rachel Danter's commentary there. I think Rachel is showing equal frustration, and I think as I've said, there's been some resource release from George Eliot to help galvanise our partners really, and to get them all in the same sense of urgency. But we're not seeing the innovation and the pace that we should be seeing.
Keep us briefed, Fiona. Clearly an issue. Glenn, did you want to add to that?
Yeah, just to pick that up, it's been given quite a high score on the risk register from a system perspective. CCG are fully aware of the impact it's having on us and on those individual patients. So I think they're taking it seriously. The resource from George Eliot is the Chief Operating Officer from George Eliot, who has a mental health background, who's going to help us to bring a bit of independent challenge to it, which I think is really, really helpful. So hopefully we'll see an improvement.
Yeah, no, Stephen's a good man. And Charles?
Yeah, just to add, I mean, the risk particularly gets more severe come the end of November, when we're expecting the peak of our winter respiratory syncytial virus in children. Because of the modelling that's been done in Australia, that could well mean that we're having to keep some sicker children on site than we would otherwise. So not having CAMS patients in our paediatric beds is going to be really important come the end of November.
No, risk well recognised. Thank you, Charles. Okay, colleagues, thank you, Fiona. Good to see the indicators moving broadly in the right direction, apart from children in crisis. So over to you, Helen, please.
Thank you, Russell. There's nothing in particular that I want to highlight, with the exception of the elective recovery and accelerator programme. So within the report, you're seeing our position for June. And for June, we did achieve the elective recovery target, as detailed there within the paper. However, we didn't achieve the trajectory against the accelerator programme. However, for July really is the month where we're expected to deliver 120%. I can say that for July we haven't delivered the 120%. It's probably about 103% at the moment, give or take 0.1 or 2%, and that's likely to rise to about 105, 106%. And I think the reason I wanted to highlight that here was particularly around the challenges that we've talked about, and I think I have put it in my report around, as we jokingly call it, the pingdemic, and that's had a significant impact on services, with many of our clinical teams being unable to either work safely, or we've seen gaps in rotas, we've seen gaps on the wards where the wards have been significantly challenged, and across a number of specialties and outpatient activity. And so whilst the teams have worked exceptionally hard to deliver that, I think there are many outside forces that have worked against us in relation to delivery of that target. And I think the rest of the paper speaks for itself with the pressure that's been seen across the NHS. I'll just take questions, Russell, and you're on mute.
Thank you, Schoolboy, again. Thank you, Helen. Questions and perspectives, Glenn?
I think we continue to do well despite that. I mean, none of the accelerator sites are going to get to the 120 for very similar reasons to ours. But I think looking at the Midland stats on elective and cancer recovery, and we discussed some of this in workshop this morning, we are doing very well. It will start to become hard to track though, because the better you do, the more likely you are to be asked to offer mutual aid to other systems at the moment. So we'll start to appear busier as we deal with our waiting list from activity from other areas. So we'll just have to try and factor that in as we look at performance moving forward. But it's a really good effort by everyone. But you know, these are challenging times. But be able to do more activity than we did in 2019, when we were doing a lot of activity, including having a vanguard on site, additional theatre, is quite remarkable.
Well done, Helen. Any other questions or perspectives? Helen, can you thank all of your reports and everyone who's been involved in making those elective numbers in particular happen? Look forward to seeing things improve when the pandemic comes to an end. So I think we're then on to the people and organisational development report. Sarah, great to see you. What would you like to pull out?
I think there's not much to add to Gertie's summary that Helen read out in the introduction. Recruitment does continue to go well, and we're planning a recruitment day focusing on non-medical clinical staff, so nurses and AHPs, and we hope to be able to do that outdoors, so it's COVID safe. Sickness has gone up slightly, but actually remains comparatively low across the organisation, and we've certainly seen a significant reduction in COVID-related sickness absence. As everybody said, it's the self-isolation as a result of the pandemic that's the issue that we're facing.
Yep. Thank you, Sarah. Any questions to Sarah? For members of the public, one of the things we talked about in workshop was the challenges we will definitely face in terms of demand over the next 3 to 5 years, and therefore the recruitment challenge, particularly as people retire and some of our more experienced clinical and surgical colleagues retire who are extremely productive, was one of the bits of planning that we are doing anyway under Sophie's direction, but over time we'll make members of the public aware as to what those trends look like, because clearly on the demand side things are very tough. We'll move on then to the money. Kim, how's the money?
Thank you, Chairman. So for Q1 we're reporting a surplus of £53,000. Work continues to carry on in respect of H2, and a further update is being provided to the board in the confidential session later. The position of the first quarter does include an estimate of what we believe we will receive in respect to the elective recovery fund and accelerator in both income and expenditure terms. I just wanted to draw the board's attention to the fact that there has been a change in the threshold for the elective recovery fund for August and September, where we now need to deliver 95% of activity from valued of activity for 19-20 as opposed to 85%, and that will obviously impact on the ability to earn an additional elective recovery funds. But again, to remind the board that this is dependent about performance across the system, not just about our own performance against elective recovery. Progress on our CPIP plans remain challenging as teams are focused on operational delivery of services. However, the divisions are bringing back plans to the next Finance and Performance Committee in due course. You will see that productivity measures demonstrate continuous improvements in productivity, and again we'll discuss that further in a confidential session. Despite this, the forecast for H1 remains a break-even position. Cash position remains strong at 36 million, and the other thing I wanted to draw your attention to, sorry, I've been attacked by a fly, is the fact that I've drawn out some further information around the better payment policy. So this is getting a bit more national focus, so I wanted to draw a bit more information about that. The main target is around achieving 95% of suppliers within 30 days, focused on non-NHS suppliers, and you will see that we are making improvements on a monthly basis on that. Performance on NHS is affecting the overall figures. We are doing some detailed invoice pathway work to identify any specific reasons for any delays, and also the focus on moving to no purchase order, no pay will also make an impact on improving that performance. That's all I wanted to draw out. Thank you, Chair.
Thank you, Kim. Questions or perspectives to Kim? Glenn?
I just want to flag something I know we've discussed previously as a board, which is that, as Kim mentioned, the elective recovery fund is paid at system level. There is therefore a risk that we could be doing activity that is not paid for if the system overall doesn't achieve that threshold. The raising of the threshold from 85 to 95% makes that a more real threat. I think our position so far, and I'm seeking confirmation from us all, has been that we want to make sure that we treat our patients as quickly as possible and recover from COVID as quickly as possible. But there is a risk that we could be doing some activity we don't get paid for. But rather than put the brakes on, which I think some trusts may be considering doing, I would rather we manage that risk moving forward and try and continue to do the activity levels that Helen's just described.
So just on that point, please put up, if you can take your digital hand down for a second, please, Chris. Please put up your digital hand if you think we should be focusing on the money or focusing on doing as much work as we can to help our citizens minimise their waiting time. So no member of the board is saying we should be chasing the money at the expense of doing the work. So I think that answers that question, Glenn. Thank you. Bruce?
Thank you, Russell. The commentary, Kim, on the executive summary, it refers to the ERF and the first quarter payment values. This is the first, I think, assessment of monies that are coming through and divvying up as income through the system. And I accept that it's approximate at the moment and it'll come through eventually as hard. Do we think that's appropriate and equitable as a split within the system?
Yeah, yes, we've been around the houses with obviously my respective colleagues in terms of coming up with a methodology that's fair, and I think we've all come to the conclusion that the methodology that we've come up with is fair and reasonable.
Okay, thank you.
Can I build on that, because that's what I was just trying to get a feel for, Kim. So this year we expect to get 342 million, of which 317 is from activities. If it were on a PBR basis, you may not know the answer to this, but it would be great to know what you think the income would be if we were being paid on the old PBR basis. I understand your point on the fair, given the amount of money we're given, you feel it's fair the way the allocation occurs, but I would like to understand actually if it was on the old PBR basis, what that 317 would be. Did you want to go and try and calculate?
We can take that away. We can take that away.
Don't do too much work on it, but my sense is it would be higher, and significantly higher than the 317. So whilst the money's being fairly allocated, actually, if we were doing it on a PBR basis, I think we would be getting more than the 317. Any other questions to Kim? Okie dokie, thank you, Kim. So I think we're then on to mortality. Anything you wanted to pull out on mortality, Charles?
No, particularly as we've got the 6 monthly report on learning from deaths coming up, so it's all covered in that. But the mortality remains well within control limits.
Okay, great. Thank you very much. Any questions on the mortality report? Bruce, your hand is still up. Is that a legacy hand? Okay, thank you, Bruce. So we'll move on then to the monthly staffing, monthly safe staffing report. Fiona?
Thanks, Russell. So this paper is your normal monthly paper that now covers all clinical staff with the exception of medics. There, as you'll see in the report, there are some services that, as Glenn suggested, are struggling with sickness and self-isolation, but generally we're in a good position. I want to just say we need to watch the vacancy position carefully in registered nurses. We've seen a very good downward trend over the last 18 months, but it has just tipped back up again to March 2020 numbers. So I'm going to be watching that carefully and doing some analysis as to where those vacancies are coming and whether we're going back up to prior COVID position, which we would not want to do. But that's my only slight anxiety this month.
Thank you very much, Fiona. Any questions or perspectives to Fiona? Please raise the digital hand. Okay, thank you, Fiona, and thank you for your hard work. We'll move on then to committee reports, the first of which is the Clinical Governance Committee report from the 14th of July. What would you like to pull out, Bruce?
Yes, a few points. One under the general point of one, saying the coroner has certainly noticed that we need to include in our root cause analysis our computer systems and whether or not they are contributing to the issue that is being debated. And we talked about that quite considerably in clinical governance. We are concerned under item 7 that there's a continued non-compliance by Coventry and Warwickshire Pathology Service in really not answering the questions that we know work very well as giving us assurance in clinical governance. And item 10, once again, a great year for infection prevention and control. Thank you. And let's focus on the 9% of the trust staff who have not yet been vaccinated against COVID. And I'm happy to take questions.
Super, thank you, Bruce. Any questions or perspectives to Bruce? Glenn? Oh, sorry, Fiona.
Yeah, I just wanted to pick it up a member of the public question from a governor that I've received in relation to those staff vaccinations, if I can at this point. Roger's asked a question about whether we should be taking action on those staff that have not been vaccinating and mandating it. At the moment, we haven't had that direction nationally or regionally. And personally, if you were to ask my opinion, I think it should be the flu vaccine that is mandated before the COVID one, bearing in mind we've been asking staff to be vaccinated against flu for many, many years, and the risks are the same. So that would be my position.
Thank you, Fiona. Okay, so we'll move on then to the Finance and Performance Committee report for the 6th of July. Simon?
Thank you, Russell. Overall, I'll take the report as read. The committee continues to be significantly assured. And I'll just pick out a couple of points, really. One is, I think it's good to see much greater reporting on productivity. And one of the things we have discussed is that you'll see a lot more of the so what questions answered in the board paper in terms of what's actually happening to improve productivity, which I think will be a good thing for the board to see more fully. I'll reiterate the point Kim has just made that SIPs are quite a way off the pace and there's a lot of work needs to be done to pull them into line. And it was very good this morning to hear the good work that Harkamel and the cancer team have done on these small but significant steps in process control that will improve our performance. My last point is to say Pathology Network will be joining us at F&P in the September meeting, and we'll understand a bit, yes indeed, and we'll understand a bit more about that when we talk to them there. And that's it. Happy to take questions.
Thank you very much, Simon. Any questions or perspectives to Simon? Okay. Trust knuckle dusters will be provided for when the Pathology Network want to join us. Or I'll get Sue Pike, given she's a downgrade at martial arts involved in the discussion.
Make a point.
Yeah, the patient experience quarterly report. Fiona, back with you.
Yes, Chair, thank you. I'll take this paper as read. The 2 or 3 things I just want to pull out. It's a good quarterly report with positive feedback from patients and very few complaints compared to our activity. We have seen a dip in performance in relation to our response rate, and that's associated with a couple of senior people being absent from work over this quarter in the emergency division and the women's and children's, but that's now being managed and back on track. The PALS team have seen a change in their PALS activity, and through COVID and online and them working more remotely, they've seen an increase in emailed concerns rather than written paper or telephone concerns. Email is actually working very well for the public. They ping emails backwards and forwards and get a good response. So I think that's probably a continued trend. You'll see that I've included some of a summary of the volunteer services, and I just want to take the opportunity to say thank you to all of our volunteers. They're a fantastic group of people that really make a big difference to patient experience, and we should be celebrating them. Otherwise, happy to take questions.
Thank you, Fiona. Any questions to Fiona on the patient experience report? Fiona, you just mentioned our volunteers there. Can you just brief me? Apologies, I know we spoke about it a few weeks ago regarding the patient form getting access onto the site, but where are we with that?
We are going, so I've asked the manager of the volunteer services to go back through, as we have done any other member of staff, the risk assessments related to their specific risks of developing COVID and the longer term effects of that if they were exposed. And so it's easier with the lower risk members of staff, but they are having those conversations in terms of their appetite to take that risk into their own hands, really.
Okay, thank you, Fiona, because we are blessed with our volunteers, and again, just to put it onto public record, our thanks to everyone who does volunteer, but we need to keep you safe as well. Colleagues, happy to move on to the CQC update, including the insights report. Fiona, back over to you.
Yes, sorry, Chair. I'm not sure why I've got 7 papers today. Anyway, so take this as read. A bit more detail this time in terms of our position related to all the information that the CQC has holds about us. Reassuringly, there's no surprises there. The areas that we're lower than benchmarked other organisations, we know of that. And we're working on it, or it's very small numbers, or it's very old data. So it's not flagging any risks that we're not aware of. So I think it remains a strong position.
Okay, great. Thank you, Fiona. Any questions to Fiona on the CQC update? We'll give your voice a break now, Fiona, as we go to Helen on the Digital Health Board quarterly report.
Thank you, Chair. I always love this paper because it's always so positive in terms of how hard our digital technology teams work over the quarter. So there's a lot of detail in the report, which is all really, really positive, and just wanted to turn our attention to our forward look, which highlights full implementation of the ED system, Nerve Centre, which we're hoping to see go live towards the end of October, beginning of November, which will be great, ready for winter. Our final go live of the patient portal in August for all of the remaining acute specialties, and this has been a real success for us in terms of the engagement and the numbers of patients that we have already signed up to this. And I think it's probably quite a positive thing to do during COVID, because people are more likely to want to use emails and work remotely. So we've had really, really great engagement. We've also mentioned in previous reports the transition of the ICT services, and also there's been a planning process around our future projects, and how we are implementing a new process around electronic referrals. And then you have one of Adam's lovely graphs at the back talking about digital innovation. So I'll just take any questions.
And it is fantastic, the level of digital innovation which has been encouraged bottom up. I think it's a real success of the whole of the foundation group. Questions on perspectives, Bruce?
You beat me to it, Russell. It's a really engaging, very useful, essential set of stuff that's happening here, and we've got to get everybody into the 21st century as rapidly and as reliably as we can. I wondered, could someone update me on the mortality system, which I think was due Wye Valley or its replacement?
That's shall I do that, Chairman?
That'd be great, Charles. If you
That's actually discussed in the Learning from Death report coming up. It's the one disappointment in that area. We actually got the system from Wye Valley, but having road tested it and connected it up, it really wasn't fit for purpose. There is a national system coming in a few months. And we've also looked at another off the peg system, but the view is that we will try and develop something interim while waiting for the national system. So that's where we are with it.
That's fine. Thank you. And can I just ask the other half of the question? The portal is very well received from the people I've talked to who have been using it. And I wondered if we were inviting feedback from users in order to just sew up the few wrinkles and frustrations that I know that are there.
Let's just note that, and well, I assume that's happening, but let's just note that and ask Adam maybe to come back on how that's happening. Thank you, Bruce. Not fit for purpose is the way my wife often describes my DIY. So the update on the Ocondom report. Fiona, back with you.
Yes, thank you, Chair. So this is not a normal report, so I'm very happy to explain it in more detail if needed. But so as you know, the Ocondom report was published nationally in December last year, and all maternity providers were asked to respond with urgency. I think by March, I think the deadline was an initial gap analysis against a number of recommendations. This was then followed by a wider gap analysis, which required significant lines of evidence to be submitted. We've met all of those expectations and submitted everything accordingly, and have been left with a relatively short, considering the evidence that we submitted, action plan, which I'm very happy to bring back to board and clinical governance as often as the board want me to. I think the message I want to give to the public particularly and to the board is that I believe our maternity services are safe and that they are in no way comparable to those described in Ocondom. I think we've got a very good safety culture and a good MDT working within maternity. Our staffing position is safe. We have days where we've got high sickness or high maternity leave, but they have a robust escalation process where they can pull the senior midwives to support women. The areas of non-compliance you can see within the action plan, but in terms of the executive summary, the current position is around information pathways from the maternity unit up to board and back again. So the further development of the executive and non-executive safety champions and their involvement within the staff, and safety conversations within the maternity services, but also with the women and partners of our patients. Strengthening the training. Now we've always regionally been commended for our training and the detail and robustness of our training, but one of the elements in Ocondom was that the obstetrics needed dedicated time to do that training and to support the leadership of that, and that just needs to be worked into their job plan. So that isn't that we're not doing training, we absolutely are, and we do more so than other areas. So but it's about making sure people have got time to do that. And the other around training is about making sure the funding that comes in from Health Education England is ring-fenced for that training. The elements that are slightly out of our control are there was a recommendation about safety incidents being peer reviewed across systems, and the terms of reference of that peer review and again the dedicated time that will take being funded is something that we are waiting for both funding and sort of more specific guidance. And then the fetal medicine pathways rely on UHCW and the women's in Birmingham just agreeing those pathways. Again, work is going on and we're progressing it, but they're not quite finalised yet. So in summary, I'd assure the board that our maternity services are safe, and we are not in a position where we would have any sort of significant reputational or safety concern in our maternity services, but we're not sitting back on our laurels, we're not complacent, and there are still areas that we would want to continue to improve.
That's good. Good summary. Thank you, Fiona. Any questions to Fiona? Rosemary?
Hi, Fiona. Fiona, should I be worried that given we didn't get the full amount of funds that we asked for, that we're not going to be in a position to fulfil all our requirements to meet the Ocondom report?
The team are just working through that. So you're right, we had part of our funding and we need to now go back and say, okay, how can we do it differently? So the expectation is still that we fulfill that request, but we may have to do it in a slightly different way.
I think it's correct to say, Glenn or Fiona, correct me if I'm wrong, that the level of funding given in total isn't enough to do what the Ocondom report is asking for. Many trusts got under the amount that they asked for, so I don't think we're unusual in that.
No.
Glenn?
Yeah, it's another one of those situations where bidding for funding has taken place rather than each trust getting their fair share. So I suppose you could take it as a compliment that we're not going to get much funding, because the funding is going to some of those maternity units that you see on the news.
Yeah. Can I just ask a couple of questions, Fiona, which you may not know the answer to, which is fine, but could you come back to me? The first is, in the last month, were there any women in the process of giving birth who didn't have one-to-one care from a midwife?
I don't know the numbers, but there will have been, yes.
Okay, so can you come back to me on that? And the second is, what is the ratio at SWFT between midwives to pregnant women?
birth to staff nurse, midwife to birth ratio is it changes by the day, but it's currently at about 1 to 28.
Okay, great. So that I think is the gold. Correct me if I'm wrong, Glenn, because we talked about it yesterday. I think the gold standard is about 1 to 28.
Yeah. So that's the expectation. A lot of units can't achieve that. As Fiona said, obviously it varies a bit, but that's our establishment that's set at that, and our recruitment's pretty good.
Okay, great. And can you thank the team? Because I believe Sarah Noble, who leads the team, is still off unwell. But can you thank the team for all their hard work? Colleagues, happy to move on? So we'll move on then to Charles, the 6 monthly update on trust performance against national guidance on learning from deaths.
Yeah, I'd just like to introduce Dr. Garcia, who is with us as our new AMD for governance. He may want to take some questions on the report. But overall, this is a very reassuring position. The mortality indicators have remained within control limits for several years now, and there's a trend of improvement. The learning from deaths, mortality review process has also been improved. And the medical examiners for deaths are in place and promptly reviewing all the deaths. You will see that there are good mechanisms for actually disseminating the learning from these reviews. And there is the one recurrent issue that tends to come up, is that we're still not as good as we should be at actually identifying patients are dying. And that is something that Fiona and I are going to commission a piece of work to actually do some training with actors and actually sort of improve recognition skills around that. I've already mentioned the issue around the IT system, which is really the one negative in this report. But I guess if there are any questions, I'm sure Dr. Garcia would like to take the opportunity to answer them.
That's great, Charles. Always good to be able to delegate the answer of questions to other colleagues. Questions?
That's okay.
Questions to Dr. Garcia, obviously, Charles.
Well, it gives him a chance to make himself known.
I'll ask you a question, Dr. Garcia. What's your biggest worry in this area?
As you can read in the report, and Charles has already mentioned, the big worry is about our IT system to support the database, the collection and the integration of all the different aspects of the mortality review process. That is something that the board could be assured that with an interim piece of work that we are going to be doing between the medical examines officer, myself, and the data officer of the trust, we should be able to have an interim system until the national kind of almost mandatory system just kind of sweeps over in a year, in a 12, 18 months time. So it's something that will improve. I mean, just by default, we will have our interim system just to collect all the data and have unified data at the same time that we improve we even move forward the mortality process. So I think that in one line will be the IT system that we should improve within the next 12, 18 months.
Thank you, Pablo. And as Helen sort of put into the chat box, congratulations on the new role and look forward to seeing you and the impact you have. Thank you for joining us today. Colleagues, happy to move on? Okie dokie. So just some items for noting. The first is the summary of ratified policies. Sarah, anything you want to add to this?
No, I'll take the report as read. There was only one policy that was ratified at July's policy review group.
Thank you. Questions and perspectives, Fiona?
Yeah, I just wanted to reassure the board about this one because I was worried when I first saw it. It is a new policy and it does refer to people under the age of 18, but I just want to make sure that people are aware that we would not be routinely admitting children onto an adult ward, and this doesn't give our staff or our systems a permission to do that, but it's going to be on exception. So maybe a teenage pregnancy, maybe going into a gynae ward if they've lost the baby, or into a maternity unit. And it will be 16 to 18-year-olds and not below 16. Where we need to recognise that their status is still a child and they may need children's services to support them, but it is in no way supporting children to be nursed next to an adult unless their clinical physician needs it to.
That's very helpful clarification. Thank you, Fiona. Okay, colleagues, happy to move on. And then the summary of reports for noting information, the Infection Prevention and Control Annual Report. Anything you particularly like to pull out here, apart from another successful year, Fiona?
Yeah, it was just a make a note of. It is a successful year. They're a great team. We've expanded the team as part of COVID, and they've been exceptional. And just want to publicly say that.
No, thank you, Fiona. I am aware that cases of MRSA are creeping up in the Midlands, so it's great that our infection prevention control are as strong as they are. Any questions or perspectives on that annual report? Okay, thank you. So we'll move on then just to some board committee minutes, the first of which is the Clinical Governance Committee on the 9th of June. Bruce, anything you particularly like to pull out?
Nothing to add for that, no. Any questions? Happy to take them. Thank
you, Bruce. Any questions to Bruce? Thank you, Bruce, and everyone involved in that. Then the Finance and Performance Committee on the 1st of June. Simon, anything you'd like to put out?
No, nothing to add, Chair, but happy to take questions.
Thank you, Simon. Any questions to Simon? So I think then we're on to any other business. Any other business, colleagues? Please raise your digital hand. Okay, there's one from me, which is regarding the date of the AGM. I do apologise for members of the public, and I apologise to colleagues because of a variety of different situations. We're having to change the date of the AGM, and it is going to be on the 8th of October. The exact details will be circulated, so I do apologise, but it will be on the 8th of October. So I think we're then on to questions from governors and members of the public. I think we've had a couple of questions. I know Fiona answered one of them. Would you care to read them out for me, please?
Thank you. So Roger Lloyd, Public Governor, he's referred to the community diagnostic hubs. The report indicates a proposal submitted to NHS England for year 1 funding, and the third bullet point speaks of a permanent MRI is accommodated in the new build at Stratford Hospital, and year 2 to 5 suggests a 3-storey extension to the new building 1. What is the difference between this and the MRI installed on the ground floor of the new building 1 underneath the Rigby Suite and opposite Cafe Lomas? Are 2 MRIs required on this site? I think Sophie actually covered that in her report, but I don't know if you want to add anything.
No, just to say we are looking to have 2 MRIs because that's what the data is saying in terms of growth.
Okay, super, thank you. And other questions, Sarah?
So another question from Roger. What is the Burton Contract referred to in the Director of Operations commentary in the Integrated Performance Dashboard under pathology turnaround times, noting the appalling imbalance in the network turnaround times for haematology of 31% in 10 days, disgraceful and very disappointing in view of the comments from the director that the pathology board did not acknowledge that turnaround times were affecting diagnostic targets. Helen, I think, is going to answer that one.
Okay,
I think Glenn got his hand up for that. I don't mind answering. I thought did you put your hand up, Glenn?
I wasn't sure whether you were taking it or I'm happy to, but if you're ready.
On the basis of delegate upwards all the time, Glenn.
Okay, so the Burton contract, just to be clear on that, so that's a contract to provide histopathology support to the Burton NHS Trust, and we were informed, and that's delivered by our Warwick service here. That was we received notice a year or so ago that they were going to move to their new partner of Derby Hospital. So we know that contract will come to an end. When it comes to an end, there's some more capacity available, and we're looking at how we could utilise that. My preference actually is for that to be utilised by other parts of the group, George Eliot and Wye Valley particularly. So we're working on that at the moment. I think the issues about turnaround time are really valid, and that's why we've discussed this before at board. That's why, as we heard earlier, the pathology network are being invited to Finance and Performance Committee. That's why we've been asking for a pathology stakeholder board, and we're informed that we're going to have one in September. So we will be working hard to ensure we can improve those turnaround times. A combination of things that the network can improve, and hopefully a bit more freedom that we can have locally on the Warwick site, because we've got some really exceptional consultants that if we could liberate them and use that spare capacity that's coming up, we could get a much better service.
Yeah, I think the only thing I would add is if we were to have a contract of any kind with a outside the NHS commercial organisation and they fail to deliver, people would quite rightly criticise us if we didn't have some penalty clauses in that contract to be able to claw back money for poor performance. Unfortunately, within the NHS, we can't have those type of clauses for NHS partners. And the problem there is there's no consequence of poor performance. And so that is just the reality of the way things work. And so, any other questions?
No, thank you. As Fiona did address Roger's third question. Thank you.
Great. And Roger, thank you very much for the diligence, comprehensiveness and range of questions you ask. Just as I've got a couple of minutes, any other questions from members of the public, please raise a digital hand if you have. Okay, I can't see any digital hands, so thank you. So our next meeting is on the of September. Just trying to confirm the date myself. I know I'm on holiday for it, which is probably the reason why I can't remember, but I think it's the 8th of September.
It's the 1st, Russell.
I knew it was. It's on the 1st of September. I'm back on the 8th. So Bruce will be chairing that meeting. So thank you very much, ladies and gentlemen. I look forward to seeing you in October. Board, we will have a 5-minute stretch break and get back together again at 25 past for the confidential board. Thank you very much.